Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has music here, a guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speaker today. Joining us today, we have Dr. Brandon Law. Dr. Law is a rheumatologist in the Division of Rheumatology, Allergy, and Immunology at Mass General. He is also a member of the Center for Immunology and Inflammatory Diseases. Dr. Law currently performs basic science and translational research in Sjögren's disease. He joins us today to give a talk on Sjögren's disease. So please join me in welcoming Dr. Law.
All right, thank you so much. Let me just share screen here. Okay, and everyone, can you hear me? Okay, great. So thank you so much. I'm so glad to be able to do this Blum Center talk on Sjögren's disease, or should I say Sjögren's diseases, and why one size doesn't fit all. And I entitled this talk, and I think it will be a little bit self-evident as we progress through some of these slides on why I don't think one size fits all for all patients. So no financial disclosures. And in terms of what I wanted to talk about today, many of you in the audience may be a patient with Sjögren's disease and may be very familiar with this condition already. Some of you may have been told that you might have Sjögren's disease through a medical encounter, and others of you may have maybe read about it or are curious about it and are curious about it for yourself or a family member. But may have not seen a physician about it yet. Whether you're in one of those categories or the other, I think this talk could be very helpful for you. One thing that I would like to emphasize, and which would be sort of the take-home message, the one take-home message from this talk in particular, is to really hone in on the point that there is a very, very much a diverse set of clinical presentations that could occur for Sjögren's disease. And this could impact and create challenges for diagnosis and treatment for this condition. And that's what I wanted to really discuss today. But before I do so, I just wanted to make a little bit of analogy here where, I think our scientific understanding of this disease has been evolving and will continue to evolve over time. And I have a picture here of Jupiter taken by various types of telescopes, and this one was done on the left-hand side in 1938 by the Lowell Observatory, and you can see a very sort of black and white, grainy picture of Jupiter. And then on the right-hand side, you have a colored, more detailed, high-resolution photo from the James Webb Telescope from 2022, showing that we have a lot more detail into looking into this compared to decades before. And I think the same is very much true for Sjögren's disease, where we are increasingly getting a little bit progress year after year in understanding the many nuances of the disease. And I think this also, the 1930s, when this initial picture was taken, is also pretty fitting too, because I wanted to put a little bit of context in terms of history of Sjögren's, because around the 1930s was when it was first described by Dr. Sjögren himself. So a little bit about the disease itself. It was first described by Heinrich Sjögren, who was a Swedish ophthalmologist, who called it Sjögren's syndrome, and we now sort of are using the term Sjögren's disease instead, but those are two of the same things. And back in the 1930s, he had described a case of a woman with what we call hyposecretion of the lacrimal and salivary glands, which is basically a scientific term for not a lot of tears, not a lot of saliva. And there was a thought at the time that maybe this was due to an autoimmune disease attacking those glands. Forward a couple years, he wrote a thesis to the Karolinska Institute describing a population of about a small cohort of 19 patients with this sort of dry eye, dry mouth type disease, along with arthritis. So there was a thought that maybe that this disease entity might be probably rheumatologic in origin, though it was not really described in any systematic way at the time. So this was sort of the first initial descriptions. But it was initially thought to be quite a rare disease when it was first described. But as time went on, it's now known to be a lot more common in terms of rheumatologic diseases that people are diagnosed with. And now that it's now more described more readily, we've now know that although it primarily is described as an autoimmune disease of the salivary and lacrimal glands, the glands that make saliva and tears, it doesn't exclusively live there. It could also involve other parts of the body, which is what creates a lot of sort of mystery and challenges of the disease itself. So some quick epidemiology, just so people kind of have a little bit of a context here. The New York Times wrote an article in 2008 calling this an autoimmune disorder in camouflage because it really can affect people in ways that appear quite sort of invisible to an outside observer. It's estimated that up to maybe about 4 million people in the United States have it based on the Sjögren's Foundation estimates. It primarily affects females in about a 10 to 20 to 1 ratio, depending on what study you look at. And it typically impacts people that are around, it could be as early, sometimes when we look at these studies in the 30s to 50s, though, we've definitely seen patients with the disease in certainly earlier years of life, and diagnosis around age 40 to age 60. And these estimates are based on our current understanding of patients who meet classification criteria. But what about the patient experience? So this is a few graphics from the Sjögren's Foundation itself. Now, on the left-hand side, what I think is the most important thing really is not to really look at the text here, but look at where the arrows are pointing. And it's showing ways where Sjögren's disease can affect the body. And you can really see it goes from head to toe. People can have neurologic issues related to concentration or inflammation of the brain, all the way to dry eye, dry mouth, as mentioned. It could affect the GI system, the lungs, the joints, down to the feet with neuropathy. So it could really affect many parts of the body. And then when we look at the symptoms that are experienced among respondents that have the disease itself, you can see many of these symptoms. There's a whole diversity of symptoms that you can see here, and all with different amount of prevalence. But you can see here on the left-hand side where vast majority of patients, in fact, describe sort of this collection: dry eye, dry mouth, fatigue, and joint pain, as you can see highlighted here, and very much experienced by many patients. And so this has led to these being the commonly recognized manifestations: dryness, pain, and fatigue. So within that category, we can even break it down further. We can have dryness that involves different parts of the body: eye, mouth, skin, nose. Vaginal dryness is also very much under discussed in medical offices. Pain can be joint pain. But it also can be nerve pain or muscular pain, and fatigue can be a physical fatigue of moving upstairs or walking to do errands, as well as sort of this mental fatigue, not being able to feel well rested, or even something closely linked to this, a type of sort of brain fog type phenomenon as well. Now, while these are what I think most medical people would describe as the commonly recognized manifestations, there are also these less recognized systemic manifestations. So what do I mean by that? These are manifestations that include things that are outside of dry eye, dry mouth typically. They can involve rashes that are immune in origin. They can include inflammation of the lungs. So here is a CT scan of a patient's lungs showing areas of inflammation with the arrows. There can also be a variant of Sjögren's where there's inflammation of the brain that looks sort of like multiple sclerosis. There's also here, this is an MRI scan of the head, and there's the parotid gland shown here in white, and that is very much enlarged. And so that can be indicative of a glandular manifestation as well, with glandular enlargement. And sometimes these patients are at risk for developing lymphoma. So this is definitely something that people are increasingly recognizing to be what we call the systemic manifestations, and can go beyond merely dry eye, dry mouth, though, of course, that is also a very important symptom to acknowledge as well. We can score the amount of systemic activity through a scoring, sort of a consensus scoring index called the ESSDAI or SDAI. And sometimes this is used in clinical trials to measure disease activity or in clinical studies. Now, there's some controversy about the SDAI itself. Some people think it doesn't capture all disease activity very well, things like that. But I think it is at least a useful framework when thinking about just trying to be a little bit systematic about thinking about whether or not these organ systems may be involved for a given patient. So this presents a challenge, as you can see here. It's difficult to diagnose, I think, especially in early stages. I'll show you a little bit of evidence for that later on in the talk. But you can see that it's very heterogeneous, and the symptoms are very nonspecific: dryness, pain, and fatigue, for instance. So it's heterogeneous in terms of symptom burden and disease activity, which makes it very much a challenge for diagnosis. Now, there are antibody blood tests, biopsies, imaging modalities that we could use which can help sort of arrive at a diagnosis, but these tests also have limitations as well. So I'll talk about that a little bit more in a second. But if we just step back and think about, which one of these patients has Sjögren's disease? Here's an example of patient A having salivary gland swelling. She describes normal, when measured in clinic, she had normal tear and saliva flow measurements, but her blood test for Sjögren's, her quote Sjögren's blood test, was abnormal, as well as her lip biopsy. So that was interesting. What about patient B here, who denies actually having dryness, pain, and fatigue, what we would be considered common symptoms, but does report that her Sjögren's blood test was abnormal? So what does that mean? Upon further review, she had abnormal kidney function and a lot of inflammation on a kidney biopsy. So what does that mean? What about patient C here, who has dry eye and salivary gland swelling, but reports that her blood test for Sjögren's and her lip biopsy was normal? So you can see here, there's a lot of variations here of patients that might have some collection of symptoms, some collection of tests that may or may not sort of support a diagnosis of Sjögren's. But in fact, these are all patients of mine, and actually they all eventually were diagnosed with Sjögren's. So that's a little bit of a trick question, but I think this kind of shows you how there could be a lot of variations of a theme when evaluating a patient with Sjögren's. So how do I think about it when a patient comes to see me in particular? I think about using a comprehensive diagnostic approach. This includes evaluation for objective evidence of dryness, the eyes, ocular dryness. I'll talk about that in a moment. Evaluating for dry mouth or salivary involvement. So that could include imaging the salivary glands, they're around the cheek and in the neck region, as well as looking for features of underlying autoimmunity, which could include blood tests that could be supportive of a diagnosis of Sjögren's, called the SSA antibody or the Rho antibody. This antibody is seen in about, depending on what study you look at, 70% of patients with Sjögren's have it, but that leaves a large a portion of patients that have normal antibody testing. And so what do we do? Sometimes people are referred for what we call a lip biopsy, a biopsy that's done in the inner lip. It's a very quick procedure that could be done. And then we can look for evidence of inflammation in the salivary glands through this small biopsy. But we could also look at other features of underlying rheumatic disease, which means low blood counts, joint swelling, these sorts of things, other antibodies that could help support the idea that there's an autoimmune process going on. So assessing dry eye in clinic is something that I think is underutilized, but something that is important to do. And so a Sjögren's dry eye exam could include either seeing, an optometrist or an ophthalmologist. I would recommend that patients that are concerned about this, or if there's a clinical concern, to obtain something called an ocular staining score, in which a provider will put basically dye into the eye and look with a special instrument to look for evidence of dryness of the eye. There's also something called a Schirmer's test, which is what this video is showing right here. And this doesn't have to be done by a specialized eye doctor, a primary care doctor, or a rheumatologist. We do this in our clinic. This is just another way to look at tear output for each eye. And basically a piece of paper, filter paper, is put on the lower eyelid, and the patient closes their eye for 5 minutes, and then we can and it acts as a wick to draw tears out, and we can kind of have a semi-quantitative measurement of the amount of tears that are being produced. Assessing dry mouth is very easy to perform in a clinical setting, and it sounds more fancy than it actually is. It's really like a passive drool test, having a patient drool into a cup and then measuring the amount of saliva is being made over a certain period of time. And there's thresholds that we look at to look for whether or not there is an abnormal production of saliva or not. So these are very sort of easy to perform, a low risk, cheap test that can be done that could add a lot of information. The other thing is a lip biopsy. And this is something that some patients undergo or want to undergo. And this can be done by a oral surgeon. It could be done in an ENT office. Some rheumatologists perform them as well. And basically, it's an office procedure where numbing medicine is injected into the inner lip. There's no general anesthesia or anything like that. It's sort of like going to the dentist. And then a small incision is made in the lower inner lip, and a small piece of minor salivary glands. So we have salivary glands that line our inner lip, and we can take a small piece and look at it and send it to pathology and look at it under the microscope and see evidence of inflammation that may be indicative of or supportive of Sjögren's. So on this picture right here is a normal salivary gland. And the picture on the right is a patient with Sjögren's disease. And you could see that notice that it's more purple compared to the healthy control patient. And I've outlined this area, these purple areas, with a sort of a yellow outline here. And that is the area of inflammation. Those purple aggregates there are immune cells. And a pathologist can calculate the amount of inflammation sort of in a score where it looks at the density of inflammation or per unit of area, and we can calculate. And usually, if a focus score of greater than or equal to 1 would be supportive of Sjögren's by classification criteria. So just thinking about these tools that I just talked about, you can see how diagnosis can be challenging because you need some sort of multidisciplinary expertise oftentimes. You need some sort of eye evaluation. Oral evaluation could include a referral to an ENT or an oral surgeon for a biopsy. There could be some imaging involved with the salivary glands as well. The blood testing is not perfect. That's another challenge here, especially in patients that have normal SSA antibodies. It becomes a challenge then to say to do the next step. Not every geographic area may have the expertise to perform or interpret a lip biopsy. And then the lack of awareness for systemic manifestations as well. We have to think about head to toe, what's going on with the patient in front of us. And that includes a good lung exam, a good joint exam, these sorts of things that can be other features, what we call extraglandular features of Sjögren's itself. And this leads to this idea, and we see this on a day-to-day basis, is that everyone's Sjögren's is a little bit different, and it can be really heterogeneous from patient to patient. And we don't really have a perfect set of tests that would say you definitely do or you don't have the disease. And this makes it quite a challenge. There have been attempts to make it a little bit more rigid and quantifiable in terms of classifying patients with and without Sjögren's. And so this is a somewhat controversial, but current classification criteria agreed upon in 2016. And you can see here, if I go through it here, the anti-Ro blood test or SSA blood test will give a patient, if abnormal, 3 points. If the lip biopsy shows a focus score greater than 1, which would be considered abnormal, that would give the patient 3 points. If the patient undergoes ocular staining and it's abnormal, that's 1 point. Schirmer's test, the test with the piece of paper in the eye, that's 1 point if abnormal. And then the salivary flow test, the spit test into the cup, that's 1 point. And if a patient undergoes this sort of battery of tests and the score is greater than or equal to 4, it's agreed upon that this would have met classification criteria for Sjögren's. So that's interesting, right? And what is the framework for why this is the case? The idea is that if you look at the way the math pans out here, you need a score of at least 4, which means that you really have to have at least a positive antibody test or a positive lip biopsy, which is 3 points apiece, to even mathematically meet classification criteria. And the idea being that you need some evidence, objective evidence of autoimmunity, plus, whatever set of points of dryness of the eyes or the mouth to eventually meet classification criteria. So a positive antibody or lip biopsy is mandatory to meet classification criteria by a current definition. And why is this a problem, and why it can be a problem? Why is this something that patients discuss with me in clinic? It's because a lot of patients don't meet classification criteria. And so does that mean they don't have Sjögren's? And this is where one of the points that I want to bring home is that classification criteria is not the same thing as diagnostic criteria, and it really shouldn't be used as a criteria for everyday diagnosis. Classification criteria were made for clinical trials, for clinical studies, to create a homogeneous population of patients to study over time and study therapeutics. Diagnostic criteria is what we kind of think about, or patients think about in terms of, do I meet the sets of disease definitions to meet a definition for a diagnosis? Sjögren's does not have diagnostic criteria. And so applying classification criteria for diagnosis would be inappropriate, though it does provide a decent framework to at least start, I think, in my mind. So why is this a problem? Why am I talking about classification versus diagnostic criteria? It's because my patients talk about it actually too in my visits, and it becomes a point of frustration sometimes if patients have been seen by doctors and quote, didn't meet classification criteria. And this is one of the things that I wanted to mention about rheumatology itself, that, there are some pearls and potential pitfalls for classification criteria, that rheumatology itself, and there's a nice editorial on this, and certainly there's a citation below for you to read, that rheumatology is a field of not a field, sorry, of black and white, but a specialty full of gray. And so patients can, for instance, not meet classification criteria, but eventually meet classification criteria in the future, and things like that. And so actually, I want to illustrate this with a very specific example from a patient that I've seen, where we had a patient who reported, who's younger, she had reported mild dry eye and dry mouth and was referred for Sjögren's evaluation. She had mild gland swelling. And so when we evaluated her, we did the Schirmer's dry eye test with the piece of paper, that as well as the spit test, the salivary flow test. And those were normal. They would be considered normal. They were on the low end of normal, but didn't meet threshold by classification criteria. She subsequently underwent the blood, several types of blood tests, and the SSA blood test for classification criteria was also normal, and her lip biopsy was normal. So in this case, this patient, if we went by criteria, would score a 0, and 0 is less than 4, so that therefore does not meet classification criteria. And in fact, doesn't even come close to meeting classification criteria. And so have we ruled out Sjögren's in this patient, especially scoring a 0 based on the available data right now? And I think a lot of people would think that we've sort of done our work. We did everything. She underwent biopsy. We did the flow measurements and everything like that. It's more than most places would do. But if we actually looked a little bit deeper into this patient's profile, this here positive ANA lymphocyte count of 0.5, C3 of 77, polygonal IgG of 2010, RNP antibody. All of these tests are basically a bunch of blood tests that would suggest an autoimmune process is going on. We also imaged her salivary glands, and we saw these fatty infiltration and cystic changes that are indicative of Sjögren's based on imaging. And then even though her spit test did not show that she had flow deficiency, we actually did a nuclear medicine test that actually measure the amount of flow going out of the salivary glands. There's a test you could do where dye is injected, and then you can look in real time where the dye accumulates in the salivary glands and have the patient drink lemon juice and then see the saliva exit. And what we saw, that there was a deficiency in some of her glands in the saliva to exit, and so there was evidence of flow limitation in her salivary glands. So I think this was a great case of a patient who, if we just rigidly went by the book and said does not meet classification criteria, we would have missed actually a Sjögren's-like process for her. This also presents brings up one of the other challenges that we see in Sjögren's disease, is that the salivary flow findings and the low tear output, those are usually late manifestations. We don't necessarily want to wait till a patient reaches that point where they're completely dry. So when we evaluate patients that are early in their disease process, those flow measurements might be normal for them. And that's something that has been seen in some clinical studies as well. The other thing that I think is could be improved upon as a field is that objective measurements for dryness are rarely performed in everyday clinical practice, meaning measuring dry eye and dry mouth objectively, in addition to asking the symptoms for the patient. So in this study right here, this was done in the Mayo Clinic, and they were looking at medical records of patients in Olmsted County, and they had over 100,000 subjects, and they looked through, and they about 106 exactly had Sjögren's disease. But through those records, only 9 of those patients had undergone a Schirmer's testing for objective eye dryness, and only 1 of them underwent an unstimulated salivary flow test to look for objective oral dryness. And so this really shows that when we think about classification criteria and everyday clinical practice, there's a little bit of a separation here where these tests that could be helpful are rarely actually performed in everyday clinical practice. So why is it important? Why can't the patient just say that my mouth is dry or my eyes are dry, and then we just take them at their word for it? It's not that we don't believe them, but it's just that sometimes the opposite can be true too, where patients actually don't report a high level of dryness, but in fact do have objective evidence of dry eye. And actually, there's a known discordance between symptoms and objective measurements, especially with dry eye disease, both in Sjögren's and outside of Sjögren's. So it's actually really important to get a handle on why the eyes are dry and if the eyes are dry at all, and at what mechanism that would be. There's also a sort of another kind of related point is that there's a very poor correlation between disease activity and symptoms in Sjögren's. So sort of this tension that has been seen in clinical studies that have been performed. So what do I mean by that? So symptoms obviously kind of means, what does the patient feel in terms of things like fatigue, joint pain, dryness, et cetera. And then disease activity is something that's sort of what a physician measures on clinical exam, on blood work, on blood tests that look for inflammatory disease activity, that sort of thing. And there's actually a very poor correlation between the amount of inflammation or inflammation findings a rheumatologist finds and the symptoms that a patient may be feeling on that day. And this sort of begs the question on whether or not these symptoms really have an autoimmune pathogenesis to begin with. Maybe it's something adjacent but not directly related to autoimmune activity, or maybe we have very poor tools of measuring disease activity itself, and so this is still a pain point for patients as well as clinicians on what to do next and how to work around that, and really trying to figure out how we can do better research into figuring out how we can get a better idea of these symptoms and disease activity and this discordance. The other thing I wanted to emphasize here is that sometimes systemic manifestations, meaning things that like rash or arthritis or neurologic involvement, can actually precede dryness findings as well, either subjectively or objectively. And so here's a clinical study that looked at this, where this is just the proportion of patients that fall into these categories. These blue categories here really showed where there was early onset of let's say small fiber neuropathy in 80% of cases that preceded dryness. So sometimes the dryness findings lag behind, and a patient could have Sjögren's, but may not have a lot of prominent dryness. And so that could, if you sort of anchor onto dryness too much, you could actually miss a diagnosis of Sjögren's as well, just to make things a little bit more complicated. And then the other thing here, and I think this is actually a very interesting set of studies, and it's been these observations have been seen in using other methods as well, is that we can actually take patients with Sjögren's and sort of ask them about their symptoms, whether it be dryness, pain, fatigue, anxiety, depression, et cetera, and then have them rate that in terms of severity. And then with a group of patients that have Sjögren's already. And then we can actually cluster them based on patients that, based on similarity. And we can actually look at subgroups of patients based on their symptoms. So there's actually a subgroup of patients that really have a low burden of symptoms. They might have dryness, but it doesn't bother them too much. They don't have a lot of pain. There are other versions of Sjögren's that are very pain dominant with a lot of fatigue. And then, other things in between. And we can actually, and so this fancy looking graphic on the left really shows this clustering. So each vertical line is basically a patient, and then these patients are being clustered based on this sort of heat map here. And you can see these four main clusters: this yellow cluster, this red cluster, this blue cluster, and this green cluster, all kind of having different sort of phenotypes of the disease. And what was interesting when they looked at this study was that there was this population of patients with low symptoms But sort of paradoxically, those that had the lowest symptoms had the highest amount of inflammatory activity when they looked at their blood in terms of their gene signatures and things like that. And there was another sort of version of this study done in a sort of a different way on the graphic on the right. But it did really show how we can have different symptom-based subgroups of Sjogren's that correlate with also with immunologic gene signatures that could be found in the blood as well, adding to a little bit of the complication here that we have sort of a high inflammation subgroup and sort of a high symptom burden, low inflammation subgroup. So just to summarize so far, because I went through a lot of stuff, is that I think I sort of made the case here that Sjogren's disease is just very much beyond just dry eye, dry mouth, but it's very much heterogeneous. And we really have gone far into our understanding that it's not just arthritis plus dryness and dry mouth, but with other dry eye and dry mouth, but other things as well. But it's been a little bit hard to diagnose sometimes because of the multidisciplinary expertise that's oftentimes needed. That there's systemic manifestations are often under-recognized. There's limitations with current classification criteria with the example that I showed. The underutilization of dry eye and dry mouth tests as shown by that Mayo Clinic study, and how there's discordance between subjective and objective measurements sometimes, and that Sjogren's can occur even before prominent complaints of dryness are apparent for the patient or the clinician. So knowing all of this, should we even be optimistic at all about the future of Sjogren's? And I think we should be, despite these challenges. So how can we leverage our growing knowledge of Sjogren's subtypes to improve clinical trials? And that's one of the main things I think we can be optimistic about in the future, is that as we have grown our understanding, we've been able to be a little bit smarter, get a little bit more granular, going back to this Jupiter analogy, in being able to adjust accordingly and maybe develop therapies that might be helpful for Sjogren's patients. So I get asked about clinical trials a lot. And we are also opening for clinical trials as well for Sjogren's. But if we look at the history of Sjogren's related clinical trials, many disease therapies, oral medications, biologic medications have failed. And they failed for many reasons. It's really there's not enough time to go through all of this, but I think one of the main things was really selection of the right endpoint to be looking at, and also making sure that we have the right inclusion criteria and patient stratification criteria, meaning that we're making sure that patients that are included in the trial have a specific version of Sjogren's that with specific measures that we can look at and quantify and be able to track. And so how have people and the community, how have they adjusted despite these trial failures to hopefully try to have some wins moving forward? So some companies and some institutions have been constructing clinical trials now that have been stratified based on subtypes of Sjogren's, based on the information that I presented to you earlier in a few slides ago. So if you can think about it here as a thought experiment, we have an eligible Sjogren's population here, which could have many different types of versions of Sjogren's, some of whom might have this, let's say, blue version versus orange version of Sjogren's. And, there are ways that we can sort of quantify inflammation and symptoms for patients when we look at whether or not they're eligible for clinical trial. And we can actually segregate patients based on high inflammation and low inflammation, based on kind of those criteria that I talked about before. And so when we look at this, we can actually see that we can maybe segment our population to different subtypes of Sjogren's. And why don't we just perform the clinical trial based on certain subtypes and have subtypes compared to each other versus that subtype with the placebo? And so when we have a population with high inflammation, let's randomize them with drug and placebo. And then with the low inflammation, high symptom burden group, we would give them drug versus placebo. And then from there, use endpoints that are more relevant for each population rather than a one size fits all endpoint for both populations. And actually, this is what several companies have been doing for investigational agents. So this is some phase 2 data that was published this year for iscalimab showing promising results for Sjögren's syndrome. And they did basically what I mentioned before, where they had a high inflammation group, and then they tracked basically what we can call this is like an inflammation score over time. And you could see how these curves go down over time. X-axis is time, y-axis is the inflammation score. And you can see how those inflammation scores go down over time for this population. And then in population 2 here, they also had Sjögren's, but they had a different version where it had high symptom burden, but the inflammation scores were already pretty low to begin with. And then they track the symptom score over time for patients that received the drug or did not in placebo, and showed that there was improvement there. And so this was a nice success, showing that we can actually be a little bit more precise, acknowledging the subtypes of disease and picking relevant endpoints that are relevant for specific populations and specific versions of Sjögren's. And it's not just this group. Another group has done the same thing, constructing a trial in a very similar way, using their agent, dazodalibep, showing, again, a population that is more of sort of the high inflammation group, showing the improvement of the inflammation score, versus a low inflammation group, but high symptom burden score, and showing an improvement in their symptoms over time. And the way this trial was constructed nicely, too, was that they had what we call a crossover design. So some patients received drug, some patients received placebo. Then after a certain point, they swapped. And some patients that originally were receiving placebo were receiving the drug, and vice versa. And then you can see actually that the improvements were undone when the patients switched over to the placebo. So it was another sort of nice piece of data to show additional improvement based on the drug. So just some, closing reflections and future directions here. As I'm running lower on time here, I wanted to just mention that these clinical trials are very promising, and there's now a lot of phase 3 trials going on, which is sort of the final stage of clinical trials for Sjögren's, and this is going to be a very nice for patients. One of the challenges, though, is these trials tend to target select populations, oftentimes those with the antibody to begin with. And so will these results generalize to broader heterogeneous Sjögren's populations that we know of? Time will tell. We don't know, but it is at least promising that we're getting some positive signal. And some opportunities for progress moving forward. I'm involved in research for Sjögren's. We're very much interested in trying to figure out pre-Sjögren's and people that might not quite meet criteria but have evidence of autoimmunity. So, what can we do at that juncture? Can we define a window of opportunity for treatment too? And so there's some thought that sometimes patients with longstanding disease may not improve despite therapies that are being given because there's been so much damage. So when's that right window of opportunity to really put in an intervention? Having a deeper understanding, too, of symptom etiology and distinguishing immune-driven versus non-immune pathways, too, as well. There's a lot of talk about neurologic involvement of Sjögren's and neuropathy, and to what extent that that is immune-driven is still very much an open but very challenging but interesting question as well. And that's something that folks are working on as well in terms of research. I wanted to point for some helpful resources from the Sjögren's Foundation. In this talk, I decided to really focus and do a deep dive on the subtypes of Sjögren's because that's something that people talk about a lot in my clinic visits. So I thought that it'd be helpful to focus on that for this presentation. I did not talk about, tips and tricks and things like that that people can do for their dryness or symptom coping. But there are a lot of good resources, and the Sjögren's Foundation website. There's also clinical practice guideline resource sheets that can be provided to your doctors locally as well. There's even a little tidbit about insurance reimbursement tips for dental visits and things like that. So it really is a nice set of resources that you can look at the Sjögrens.org website. And these are things that are curated by physicians, rheumatologists, things like that. So very much high quality data driven or expert opinion tips and tricks and resources here. And with that, I'm open for any questions. Thank you so much.
Thank you, Dr. Law. We are now at the end of the presentation. If you have any questions for Dr. Law, feel free to enter them in the chat. We have a question regarding lip biopsy. Why is this site in particular tested for biopsy?
Why is this site in
Correct.
particular? Yeah. Yeah, so this was a study done, I believe, in the 60s and 70s by Dr. Greenspan. So the salivary, we have major salivary glands and we have minor salivary glands. So the major salivary glands are like the parotid gland, the sublingual, the submandibular. Those make most of our saliva. And in a perfect world, sure, maybe we should biopsy those areas to look for inflammation. Some centers in Europe do this. It is very much a much higher risk procedure to do because there's a lot of nerves that go around those areas. And what studies have shown is that there's also something called the minor salivary glands, which are the small salivary glands that line the mouth. And you can kind of use that as a surrogate way to look for inflammation that we assume is also occurring in the major glands as well. And the lip biopsy, and when people have looked at it, it's not perfect. It doesn't correlate 1-to-1, but it's pretty good. And people can do this procedure much more readily because of the fact that it's more accessible. It doesn't require an operating room, and can be done sort of in an office-based setting, and it's very quick and much less risky. And so that's why the lip biopsy has been sort of, at least in the United States, kind of the go-to biopsy-based procedure for Sjögren's.
Thank you. And how is this condition managed in a cohesive way when there are multiple providers involved?
Oh, this is a very good question. It's very hard. So the best way to do it is to have a rheumatologist that is quarterbacking it, which is very hard. Oftentimes, there've now been Sjögren's like centers developing, which we do, and I trained in one as well, where there's already sort of a little bit of a multidisciplinary buy-in from different divisions that this is like a area that they want to focus on. And so then that's where the care coordination comes in a little bit more. And that oftentimes is really the key, is really having providers with a little bit of buy-in and coordination. But it does oftentimes require a little bit of investment and effort on the part, oftentimes, of the rheumatologist, who's usually in the center of managing between different specialties.
Thank you. We have a participant who is a longtime Sjögren's patient with many or most of the manifestations that you described early in the presentation, was even on a clinical trial for esclimab. I'm sorry if I'm pronouncing this correctly. Esclimab.
Okay.
Sorry.
Yeah.
How encouraging should we be about getting to the bottom of this disease, particularly for causes and cure?
Yeah. I think this is a good question. I think there's reasons to be optimistic because there's a lot of advanced phase 2 as well as phase 3 trials going on right now. I just came from the American College of Rheumatology meeting in Washington, D.C., where there was a lot of interest in Sjögren's, excuse me. And then there was a lot of clinical trial data being presented as well. And what was nice to see actually in these meetings too, where the rooms were filled, and we couldn't get, sometimes you couldn't get into certain rooms unless you came really early, which is probably not something I could have probably seen years ago. And partly because there's a lot more interest in it now, and there's a lot of interest from groups that are developing drugs as well. And I think that type of ecosystem is very encouraging. And even if one drug may not particularly work for a particular patient, it seems like with the other drugs that are popping up and that are in phase 3 or advanced phase 2 trials, there are probably, hopefully, we'll be at a place where we'll have not just one thing to provide, but we can have a little bit more of an armamentarium of biologics or other modalities to be able to treat patients much more like how we do with rheumatoid arthritis or psoriatic arthritis, where we have a little bit more of a menu of choices to do. We're not there yet with Sjögren's, but I'm very encouraged by the amount of interest that has been developing the last few years.
Thank you. And have you found that insomnia could come up as a symptom?
Yes, yes. Yeah, the insomnia, just sort of poor sleep quality in general, even is also something that can be reported. I think for those for symptoms though, just to step back, it's also very important to make sure that along with everything else, even with something like joint pain or a rash, that we make sure that it's also not due to something else. And so whenever a new symptom seems to pop up, we have to think about, is it medication related? Could have been started by something else. Did you get COVID or something like that? That other things that we want to make sure before we start attributing it to Sjögren's, which obviously it can be the case. But oftentimes we want to make sure that there's other alternative causes or reasonable alternative causes are at least investigated and ruled out.
Thank you. Our next question is do you think that the combination of ESSDAI scoring and classification criteria has been a good substitute for diagnostic criteria? Or do you think we need to reach a point where we need to define specific diagnostic criteria for clinicians?
Yeah, very interesting. I think SDI and the classification criteria as provided right now really is a good attempt. It's not very good for it's a very good I think it's a very good measure for patients that have a very textbook definition, like the ones reported by Dr. Sjögren in 1930, someone with very advanced disease with an arthritis and profound dryness with the swelling. Like if they very much follow that kind of textbook definition, I think it's like a decent approximation. I think that it's not very good for early disease. And it's kind of this funny thing that the more we learn about the disease, the more we learn that we don't know about the disease. And so I think it doesn't adequately capture some disease, especially like neurologic manifestations, very well. The other thing about classification criteria that I should mention too, if you notice that scoring, the way it's being scored with the lip biopsy, the blood tests, and the dryness measurements, that's fine, but it's very much like oriented on the glands and dryness and the blood tests and things like that. But the classification doesn't actually capture other parts of the body that we know could be affected. So it's not like lupus, for instance, where in lupus we can score patients and we have classification criteria that spans many organs. In Sjögren's, that's not the model yet. And I think people are recognizing that there's a little bit of a flaw with that. And there's no surprise that classification criteria gets revised every few years. I'm sure we're going to be due for a revision again. And so I think being able to try to capture it better will it will be very much an objective that people are going to be working on.
Thank you. You had talked about how there are specific centers dedicated to treat Sjögren's. Are there any plans for MGH to open one up?
Yep, that's what we're doing here. Yeah, so I'm now focused on, and I've been building up a Sjögren's program here. And so that's actually mostly what I see now clinically, and that's what I do in terms of a research objective as well. We do have a nice collaboration with Mass Ioneer in terms of the providers there for biopsy and obviously eye care. And then, we definitely have a lot of expertise with that. And we also have a very large neuroimmunology group that's very much interested in, and we share a lot of patients there. And so we've been building our Sjögren's program to be modeled very much like those types of centers.
That's wonderful. And do patients need to be an existing MGH patient to be seen?
Nope, not necessarily.
So I think we're about time.
Okay.
While we wait to see if there are any final questions in the chat, do you have any final thoughts to share with the audience?
Well, I'm glad I was just a little bit able to talk about the work that we've been doing, and so I think there's reasons to be optimistic about the future, and there's a lot of interest in the rheumatology, in neurology, and ophthalmology community to try to improve clinical trials or things that we are also are doing as well with regards to Sjögren's. So that there will be more information about that on our division website.
Okay. Thank you so much, Dr. Law, for spending the hour with us. This was extremely helpful.
All right. Thank you so much.
And for everyone who joined us, thank you so much. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. And if anyone's interested in that last slide with the resources, feel free to email the Blum Center, and I'd be happy to share that with you. It's at pflc@partners.org, and essentially just stands for Patient Family Learning Center. Okay, everyone. So I think that's all that we have time for. Thank you so much. Take care.